Good morning, everybody, and welcome to a very special episode of the Serdentity podcast. I am your host, Elizabeth Dewar Anthony, and this morning I am going to be speaking with the great Dr. Bill Hang. And I just can't even get over that I'm talking to him right now. So, good morning, Dr. Hang.
Good morning, Elizabeth. Nice to talk with you.
um, so we were talking about the Eastman. So we're talking about Rochester, and we're talking about Xerox and Kodak, but the Eastman Institute for Oral Health started out as the Eastman Dental Dispensary on Main Street.
I
And
I think I knew that.
I had nursing home patients that couldn't tell me what day it was, but they could tell me about their visit to the Eastman Dental Dispensary like 50 or 70 years prior.
Oh, wow.
So
Wow.
that is how powerful these traumatic dental experiences are.
Yeah. Yeah.
And right? So
That,
Serdentity is a combination of serenity and dentistry.
yes.
And I realized years ago that there was a post-traumatic stress reaction in these traumatized dental patients. But it wasn't until I became a myofunctional therapist that I understood it's the airway. People are being traumatized because they can't breathe.
Exactly. Exactly.
And what happens is the patient comes in defensive because their brain's already, their primitive brain's already hyped up. And the person presents as not even fearful, but more like hostile or angry or belligerent. And what I want to get across to my fellow dental professionals is that these patients, even though their presenting behavior can be very challenging, they are acting out of their own fear. And if we as professionals can realize that and help them to breathe better in the dental chair, things are going to go a whole lot better. So that's my story, and I'm sticking to
Okay.
it.
Yeah.
So I loved that big meeting in the Airway group about collaboration and how important it is for the dental world to start collaborating with other branches of medicine. And it's kind of exciting. You know, the ADA is finally on board with the mouth as a link to the body. And I
Right.
loved your story about how you came to be aware of these airway issues, and I'd like to hear that again.
Well, I'm a traditionally trained orthodontist. I went to the University of Minnesota ortho program starting in 1972. Finished it in 74, was asked to stay and teach, and I did for almost a year until I decided academia was not for me, and I decided I want to kind of get away from the cities. I moved to Vermont, where I'm sitting right now, as a matter of fact. And I started doing what I was taught to do. I took out teeth by the truckload, retracted, and made straight teeth. And after doing that for a number of years, I saw that the faces weren't looking so good after I was done. And I started a continuing education process in actually November of 1981. And I knew I had to do something different. I couldn't stand to do what I was doing. And I started traveling around. And it was kind of scary because here I was on my own. I didn't have someone to,
Mm-hmm.
and but I knew that what I was doing wasn't okay. So and I lived in a town here of about 18,000 people, which has actually gotten smaller. It's not very prosperous anymore. But what you do gets home before you get home. People
Mm-hmm.
know what you're doing in a small town. And so I'm trying new things that I haven't done before. And it's very scary because, I've been taught to take out teeth and I stopped doing that. Is it all going to work out or not? And as a matter of fact, it worked out very well. And I had people from all over the state coming. The dentist liked the fact that I was not removing teeth, and the patients did too. The reason I was doing it was largely aesthetic, but there was also the underlying thing of temporomandibular joint problems. There was a
Mm-hmm.
feeling in general dentistry by a certain number of dentists back in those days, the late 1970s, early 1980s. There was a specific dentist from Minneapolis, Minnesota, by the name of John Witzig, who was saying that the orthodontists were devastating faces and causing TMJ problems. I was straight out of school. I thought, who is this clown saying this stuff? I was taught to do this. And then I actually heard him speak in Albany, New York. And then I actually traveled to Minneapolis, Minnesota for another one of his courses. And I began to think maybe this guy is making some sense. And over a period of many years, I was going to courses one after the other, flying here, flying there, wherever I could. And the practice grew, and the patients were happy. They liked their faces. And then I really got into learning about the airway because I was doing a concept called orthotropics, where
Mm-hmm.
you need to move the entire face forward.
Yes.
Every malocclusion starts with the upper front teeth moving back too far in the face. And
Yes.
that we never learned that in orthodontic training. They're still not teaching that.
Right.
But I learned it from John Mew in London, England, who knew
Right.
this in the 1950s and 60s. So class one, class two, class three, it doesn't matter. The upper front teeth fall back. If you
Mm-hmm.
want the face look right, you move the teeth forward. The upper teeth must move forward, especially in a class two case. Uh,
Mm-hmm.
oh, the upper teeth stick out. No, they don't stick out. They never stick out. We've known that. That's in the refereed literature since July of 1981. In the
Wow.
refereed literature, the upper teeth don't protrude really in a class two case. And so after having done this for years, I was literally one evening in the year 2000 when I was in my California practice. I was looking at some old x-rays of some patients that I treated with orthotropics, and I saw this dramatic improvement in the airway. Uh,
Mm-hmm.
behind the soft palate was forward, the tongue was forward, the airway was open. We then did a retrospective study on about 50 or some of my patients that I treated with orthotropics, and we saw that we got a 31% improvement in the airway behind the soft palate, 23% at the posterior airway space behind the tongue, and even 9% down here. And this was in kids who cooperated and some who didn't cooperate. So it was a huge change, and it was published in the Cranio, the Journal of Craniomandibular Practice. I didn't even do the research. Someone else did it, someone with more talent than I am in terms of research. And then that really, starting in really the year 2000, I mean, I'd known a lot about airway before that, but I began to really learn about it. And the other thing really was in 1989, here, while I still was practicing in Vermont in September of that year, a woman that I'd seen 5 years earlier returned. And I had put her off 5 years before. She'd had teeth taken out, upper lateral incisors were
Mm-hmm.
extracted, pulled back. Her face was completely devastated. She had pencil thin lips. She looked like she'd been hit in the face with a baseball bat. But more than that, she had a pain pattern going on. She had a headache. She was 27 years of age in 1989. And pretty much ever since her ortho had been done, she'd had a headache for years. And in 1985, I sent her away, said, I can't help you. You probably need to have the spaces reopened, but I don't know that could be done. And she came back in 1989 and she was desperate. She said, you got to do something. And I'd done 5 more years of continuing education. I was doing a lot of different things that were working out. I had quit taking out teeth completely after having taken out teeth in more than half of my cases. I stopped that completely in the early 80s. And by the time I met her, I had been years I hadn't been taking out teeth, and I was using appliances to move the upper teeth forward. I thought maybe I could open her spaces for her.
Mm-hmm.
Promised her nothing. As a matter of fact, and I told her everything in the world, the negative that might happen. I produce an open bite, you might need surgery, might push your teeth off the bone support, you might lose teeth, you have to see a periodontist. I don't know. And
Mm-hmm.
she didn't care. She said, I don't care. I don't care. She's desperate. She's like a guinea pig for me.
Mm-hmm.
I known that her husband was an attorney, which he was, I would never have treated her. But the news was I didn't know that.
Mm-hmm.
Treated her. It worked out well. Her headaches went away. Her face got filled back out. She went to visit her mother in Florida, And her mother said, "Oh my gosh, look, you have lips." Yeah, I moved her teeth back in her face where they were meant to be. That was a defining moment in my career. I then reopened extraction spaces for another patient, and soon I did it in my own mouth. I'd had a tooth
Mm-hmm.
taken out on the left bicuspid. I reopened the space, put an implant in there, widened my jaw 7 millimeters, non-surgically. And all this, I began to learn more and more and more about the airway. Uh, and it's funny because what on all the continuing education I did back in the 1980s, uh, I remember one person, I think it was Omer Reed from Phoenix, Arizona, who's now passed away. He was a very good mentor, and he said, "You know, we dentists think we know everything. What we really need to do is to take off our white coat, sit down, shut up, and listen to the patient. They'll tell you what's wrong. You just have to be smart enough to know what they're saying.
Mm.
More than that, you have to be able to interpret that and then know, well, okay, so what does that really mean? They say something, but what does that translate to? What does it really mean?" And then you have to have in your toolbox the things to help them. And so that was my practice. I ended up I moved to California in 1996, and in 97 opened a brand new practice. I wanted to downsize, and I wanted to have a very specific practice where I was not going to see a lot of patients in a day. And I got to know my patients, and that's when the learning really began.
Mm-hmm.
Your patients. I had people from more than 30 states coming to see me, several foreign countries, and most of them had airway and aesthetic issues. And ultimately, several years ago, it dawned on me that we were really dealing with a syndrome, uh,
Mm-hmm.
and and it was a very real syndrome. I called it extraction retraction regret syndrome, ERRS,
Yes.
as in mistake. It's an acronym that my wife and I came up with. And we defined it as a constellation of aesthetic, very important, aesthetic, functional, and emotional signs and symptoms after orthodontic retraction, all of which is preventable because
Mm-hmm.
retraction is preventable. The sad part is that most, if many, if not most treatment plans in orthodontics, even today, even if you don't take out teeth, they're retractive in nature.
Yes.
We don't know how much you can retract before it causes a problem. Um, and so that's when the learning began. And you know, you listen to the patient and they say, "Oh yeah, when I finished my orthodontics, felt like my lower jaw wanted to be forward." Yeah, exactly. Your front teeth were retracted back, and you hit prematurely on them. And so people would hold their jaw forward all the
Mm-hmm.
time. Tell me this. And then they'd also say, "Well, I can breathe better too." Well, gee, what about that? People actually have to breathe. What a concept.
What?
And so one thing leads to another, and pretty soon you see that it's a big problem. And you know, you have the experience here, you've listened to people, you know what it's all about. And these people are from all the corners of the world. I've had people contact me from every continent and countries that I didn't even think there were people who would have orthodontists, very remote
Mm-hmm.
places. Uh, but I've been privileged to learn from these people, and as I treat them, and I got to the point where I knew when I was going to get a hug from somebody. I'd open the spaces and push the teeth forward, and as soon as these front teeth go like this, and I create a slight overjet, I know I'm going to get my hug because the mandible is no longer trapped. And so,
Yes.
although we learned all about cuspid guidance and incisal guidance in dental school, and yet there's not one article in the refereed literature really defining that and showing and saying that there's a long-term health benefit. Show me one article that says there's a long-term health benefit. But if you're going to listen to your patients and believe what they're saying, literally as soon as I would go like this and there'd be a slight overjet, bingo. The
Mm-hmm.
weight of the world is off their shoulders. They can breathe again. They're not in that panic mode that you know. They're not
Mm-hmm.
in sympathetic overload,
Yep.
autonomic distress. They're down regulated. They actually get into the parasympathetic mode for the first time in their life, and
Right.
it's okay. Yeah.
So people come into the dental office and they're in fight or flight. How do we expect people to understand and agree to a treatment plan when they're primitive, they're not even functioning in their neocortex? And,
No, I know.
and so first of all, I could be that woman that came to you in 1989. I was 27 years old in 1989, and I had extraction retraction orthodontics. Had class 2 division 2, and
Oh, the worst. That's the
yep,
worst because start out with a deep bite,
yep,
and the centrals are tipped back, making the lateral incisors appear like they protrude, which they don't.
right. And now guess what? I have a CPAP. I was officially diagnosed with sleep apnea in 2016, but I've been snoring for a long, long time. And so that's me. And
Yeah.
I told so many patients about your extraction, retraction, regret syndrome. That was so helpful in helping people to understand that the mouth is. I would always say, I don't know if you know this, but your mouth is attached to the rest of your body, and you know it's a system. It's a syndrome that you're talking about, but it's a system.
Yes. Talking to you, how is your jaw joint, your temporomandibular joint? Have you had X-rays of it?
I haven't had X-rays of it. I don't have many of the problems that some people do, but it definitely there's
Yeah.
noise, there's crepitus.
Yeah, it's the class 2 division 2 malocclusion when teeth are taken out and retracted back. It's the classic thing to do is take out upper bicuspids because they're
Hmm.
class, bring the teeth back, and
Yep.
you give them incisal guidance and cuspid guidance. The fact is, it ignores the fact that the upper teeth really are not protrusive in the face. In
Hmm.
every class 2 case, the teeth are too far back.
Right.
Back in the year 2000, there was an article in U.S. News and World Report magazine that came out, and there was a woman from Pittsburgh, Pennsylvania, pictured there, and she'd had that very thing done in a class 2 division 2 malocclusion, and the article really had to do with companies that have liability and go bankrupt, and what do people
Hmm.
do when there's no accountability? The fact is, this woman had, and there was a picture in the magazine. I could see she had a little nurse's hat on when she graduated from nurse's training. I could see that she had a class 2 division 2
Hmm.
and she'd been retracted. And she then had headache pattern. One thing led to another, to another, to another. And then she had a total joint replacement, artificial jaw joint replacement. Okay. And that's very common. Now, the sad part in her case was that the artificial jaw joint that she'd had done had a plastic material in the condylar position,
Hmm.
and plastic disintegrated and would go into the soft tissue
Oh,
all over. And she'd had, I forget the number, but it was like dozens and dozens of surgeries to get this out.
oh,
Uh, I ended up calling her on Labor Day of the year 2000, I think it was. And she was living, she was in her early 50s and on disability from the state of Pennsylvania. And
disability.
she only had a half a dozen, she had like 14 or 15 teeth left.
Mm.
And she was living with her mother, and she was going to have a morphine pump installed in a few days. Her life had been devastated by
Oh
this.
my God.
I talked to her for a half an hour on the phone, maybe probably even an hour. But this very thing, I mean, I've seen it so many times. That's why I ask you about the condyles. If you trap it back, you put the condyles back, you know,
Right.
and I have, the profession would say, oh, there's no relationship whatsoever between headaches and retraction. I think, oh, you're kidding. Come in, I could deliver 747 airplanes full of patients from all over the world to your
Right.
location. You can examine them. You can do cone beam X-ray, and you can make your own conclusion. I didn't come up with these ideas. Everything I'm telling you is what I've learned from my patients just by sitting down, shutting up, and listening. And if you can't connect those dots, then you really need to get into another profession.
Yeah. Yeah. Uh, you know, so I'm in these Facebook groups, dental and dental hygiene, and post after post of professionals complaining about patient behaviors, blaming the patient's rude, they're blah blah blah. Meanwhile, this patient is most likely has a mouth breather with airway issues, and oh, they refuse X-rays. I've got to get them out of my practice right now. It's like,
Well,
oh my
they're
God.
the people they haven't had a good night's sleep in their entire life, or at
Right.
least, and to them it's normal. Whatever they're doing is normal. That's life. Life is tough, particularly women. It's their, they're going to shoulder the weight of the world on their shoulders, and it's their job to just power through because they have
Yes.
to. They're mothers. They
Yeah.
can't afford to be down. They got to do everything right. I mean, I've seen it so many times, and it's sad. And then they get a sleep study done, and it says, "Well, you don't have apnea." Well,
Right,
that
right. Oh my God.
doesn't mean a thing. Doesn't mean you sleep well. The sleep studies are flawed, and there's a lot of discussion of that over the last decade, really, in the profession. People who are very well known in the sleep industry, they know that there's shortcomings, and so particularly with women. Well, they'll have what was termed upper airway resistance syndrome is now uh, respiratory, whatever,
Hmm. Yeah.
sleep apnea. They got a new name for it.
Right.
But the fact
Whatever.
is, women will not stop breathing completely for long enough to have it register as an apneic event.
Oh my
But
God.
they
Yes.
have a zillion of
Right.
these
It's
episodes, and their sleep is trashed. And they and the sleep doc, who doesn't really know this very well, will say, "Oh, you don't have sleep apnea," as if that's
like,
fine.
right, right. As if that means something.
And
Um,
they have this triad: the aesthetic, the
yep.
function, and then it becomes the emotional part. And then they've sought solutions everywhere. They spent tens or hundreds of thousands of dollars, and I've had people who've spent more than $1 million worth
Hmm.
looking for solutions over the years, over a 20 or 30-year time frame, and they can't find them. They get frustrated. And then of course, by that time, they don't trust anybody because nobody's been able to help them. They've been to, 10, 15 states, 20,
Hmm.
30 doctors, and they've been all over. And those are the people that, if you've been in this arena treating them, you better watch out, because sometimes at a certain point, they end up becoming their pain.
Yes.
They become their pain, and they're really in a hopeless mode.
So the kind of patient you're describing, what I did with Serdentity was I broke down patient presenting archetypes. And
Yes,
so that I can tell myself, okay, Mr. Jones isn't a jerk. Mr. Jones is fearful presenting as hostile.
yeah,
Mrs. Smith isn't a bitch. She's fearful presenting as hysterical.
yeah.
So this, what you just described, is exactly the description of this fearful presenting as hysterical. They come in, they're taking care of everybody else. They're on metformin, they're on blood pressure medication, and they've had a million surgeries, and they don't want X-rays because Dr. Oz said they're bad. But the real problem is she can't breathe.
Exactly.
And if I could, you know, I gave my talk the other day to a group of dentists, and you'd think I was talking about Einstein's theory of relativity. I mean, what?
It's so simple. The fact is, it's so
Yes.
simple. It's stupid simple. We live in a world where everything has to be complex, but it isn't.
It's
Uh,
not.
no, I mean, I get emails from people. I had a woman from Singapore, literally. Now think about this. The profession, orthodontic profession, we're so scared to advance teeth, thinking we're going to cause recession by advancing the teeth. That's why we take out teeth, and we ignore. I have 7 articles in the refereed literature telling you that you can advance the teeth like crazy and not cause recession. I've advanced teeth massively and not caused recession. And if there was a little recession, I wouldn't care. If someone can
Yeah.
breathe and live a better life and have a better health span, they'll trade that any day for whatever they've had done. But I had a woman
Yes.
from Singapore, had reproximation done. This is where you go in and narrow all the lower teeth down with
Mm-hmm.
a high-speed handpiece. It started out from Louisiana State University. Dr. Jack Sheraton, who passed away a few years ago, started this like 30 years ago. Didn't want to take out teeth, so you go in and narrow the teeth down. Well, that's the same thing being done. You still retract. I mean, I had a woman who had a very minor amount of retraction done by reproximating her lower incisors and did Invisalign. And she contacts me and says she can't breathe. And I'm thinking, that can't be. That can't be.
Mm-hmm.
I mean, that's silly. A little bit like that. No, who knows where that threshold is, where
Yes.
that one person you've retracted, you've pushed back against the tongue, the lower incisors hit the teeth prematurely. I mean, the tongue hits the teeth prematurely, and now that the tongue is back, and that whole sympathetic nervous system thing kicks in, and you're in fight or flight mode.
Mm-hmm.
And how far back can you retract? Years ago, I spoke to an alumni group at a very major dental school. I won't even say where. Actually tried to
Yeah,
get
this
me
was a major dental
disinvited.
school too.
Yeah, they tried to get me disinvited. The orthodontic department there did. But the woman who had invited me said, no, he's going to speak. And so I had a room like there were about 400 people in this room. And I showed a slide where I reopened extraction spaces for a woman in the upper arch only. And she'd had 4 teeth taken out, and she was one of these women who slept for 2 hours a night, laid in bed the rest of the night, tossed and turned, raising 3 adopted kids,
Mm-hmm.
and she would bite your head off if she looked at her cross-eyed.
Mm-hmm.
And she grew up in Beverly Hills, by the way. I mean, she was a woman from privilege, and she flew on a private jet wherever they went. Her husband was a very rich attorney, and they have an entertainment business. I had reopened her extraction spaces, and I was preparing her for a total joint replacement because she had degenerative joint disease.
Oh,
And she she was cooperating like crazy with the appliance, complaining because that's what she did. I mean, you've described the person perfectly. So I pushed her teeth back forward, and she walks in the office one day and she says, Dr. Hang, I'm done. I want these braces off. I said, wait a minute. We're not even to the surgery yet. She says, I don't care. I don't have sleep apnea anymore. I don't have sleep apnea. I said, what do you mean you don't have sleep apnea? We had a sleep test. We had you tested before. You had sleep apnea. She pulls out a sleep test that she's done, signed by a physician at a major hospital in Los Angeles. It said, yeah, the sleep test said she's gained 10 pounds from the previous sleep test, which would be a negative.
mm-hmm.
The weight you have, the more likely you are to have more of an apneic problem. Anyone with any
Yeah.
department head would tell you that.
Yeah, that's
And
me.
it says, despite the fact that she's gained 10 pounds, she has no evidence of sleep apnea. It's been eliminated. So I present this sleep report to this group I'm lecturing to, and I say, so I opened her spaces merely on the upper arch, not even on the lower, because I was planning to do surgery. I didn't want to take out teeth on the or reopen on the lower because I wanted to surgically bring her jaw forward, to bring her tongue forward more. But merely opening on the upper gave her tongue enough space to come out of her throat and eliminated the apnea. And so I then would lecture at this very major hotel in a very major city. I don't want to go further than that.
Right, right.
I said to the group, do you believe it is possible to retract enough to cause sleep apnea? And then no one said anything. And I said, is there anyone in the room here who believes that you could not retract enough to cause sleep apnea? And I said, raise your hand or stand up. No one raised their hand. No one stood up. There were hundreds of people there. And I said, okay. And I announced to the group, nobody has stood up. Nobody said anything. So I'm assuming that everybody here in the room believes that you could retract enough to cause sleep apnea. And I paused. No one said a thing.
Mm-hmm.
And I said, the next thing, I clicked the clicker and said, so how far can you retract before safe retraction becomes unsafe and you cause a problem? Does anybody know? No one knew. And I said, well, I don't either. I certainly don't know. I've been reopening spaces now for, at that point, more than 20 years, but I don't know.
Mm-hmm.
And And the next thing I said, I clicked the thing and said, so if you don't know where safe becomes unsafe, how can you ethically and morally retract even minutely?
Yes,
And of course, the room goes silent. No,
exactly.
no one wants to address that.
Right.
Uh, but it's a big issue. And after I wrote articles on the ERRS, I would get people contact me via email from around the world and basically identify themselves as a poster child for ERRS.
Mm-hmm.
I mean, I had I had one woman fly from the East Coast for me to reopen her extraction spaces, and she had a three-ring binder of more than 100 pages with several sections on it, and she had describing her long journey for more than half of her life trying to
Mm-hmm.
find a solution. And I was scared to death of her. I thought,
Yeah.
but I'm never going to make this woman happy. I told her, I said, I don't think, and I don't want to, I don't think I want to treat you. She'd flown out literally from New England to Los Angeles, and I was scared to death to treat her. And I said, I think you're going to need surgery to get what I think you want. And she says, no, Dr. Hang, if you just reopen my four spaces, I know I'll be happy. And my wife and I discussed it, and we decided, okay, we'll give her a chance. And so Deb, my treatment coordinator, went back in and talked to her and said, Dr. Hang agreed that he would reopen your spaces, but he's not, I've never promised anybody, not one person, resolution of one symptom. She stood up from the couch she was sitting on and looked at my wife and said, this is the best day of my life. And so then I made the appliances for her, gave them to her. She flew back to the East Coast. And about 2 months later, she sends me pictures of her spaces are opening. She's happy. She's elated. Zillion pictures. And the fact is, I ended up opening all the four spaces. She got four implants, and she's absolutely thrilled. But again, I was scared to death because I thought her expectation and what I thought
Mm-hmm.
I could do non-surgically would not resolve it for her. But I was wrong. I was happy to be wrong.
Right. You just reminded me, I had a myofunctional client, a live. I see patients online now with primal air, but when I was seeing people in person, an oral surgeon, well, a TMJ specialist referred this gentleman to me, and saying that he mentally ill, basically. And this man hadn't slept. I mean, he had everything, the every symptom you could possibly imagine, and he'd
Right.
been dismissed as crazy. And
Yep.
he brought all these pictures of himself to me, and by more than one provider, by more than one professional said, you've got some mental issues. And
Yeah.
oh my God. So he was showing me pictures of like his wedding. Okay. And then he had ortho, and they retracted his anteriors just
Yeah.
only a little bit. And this man was suffering. And so I saw him for a first appointment. We did a consultation, agreed treatment plan, and at the time I was doing hands-on also.
Yes.
I'm a Reiki practitioner, so
Okay.
I love to get my hands on people. And so he almost fell asleep. He almost fell asleep on the table as I was putting my hands on him.
Yes.
Come on. And he said, that's the most relaxed I felt in ages. So
Right.
all these people need is to be heard.
Yeah. You can document this kind of thing too. I mean, Uh, a good friend of mine has FDA approved equipment for measuring, autonomic nervous system.
Yeah.
Jeff, I don't know if you know Jeff Hinden. Jeff has this, and he basically it measures heart rate variability is the big thing that he is looking at, and he can document changes in heart rate variability that occur with this.
Mm-hmm.
we actually used that equipment for a while. We got some of it when I was in practice, and I'd work with Jeff on this, and you could see the change, and it's dramatic when you're able to reverse that for somebody, and for the first time in their life, they're not in sympathetic overload all the time, and
Mm-hmm.
not they're not ready to bite your head off, because they just literally aren't breathing, they're not sleeping, they don't have any peace in their life at all.
At all.
Yeah.
And wow. So I'm absolutely adoring our conversation right now.
And I want to make another point here, because there are people that are going to criticize me on this, and I'm happy to have people criticize me and say I'm a nutcase. That's fine.
Me too.
I plead guilty. I want to help people, and I've learned from listening to them, that. But I want to make clear that not everyone that has retraction is going to have these issues. But I want to tell you this: a huge number do.
Mm-hmm.
And it's a for some people it's more of an issue, for some people it's less. But when you learn and you even just move teeth forward, sometimes a millimeter, maybe not even a whole millimeter.
Mm-hmm.
Someone comes in and says, "Oh my gosh, I feel so much better." I mean, I had one man, he was in his early 40s, and an orthodontist had just closed some generalized spacing and pulled the teeth back. And the guy was snoring and he had
Mm-hmm.
apnea. And the guy, I actually talked to the original treating orthodontist. I told him how to reverse this and the appliances to use and what to do. And he didn't want to even bother. He wrote the man out a check in full, refunding the money completely that he
Wow.
and said, "Go see Bill Hang. He'll treat you." I wanted to help the other orthodontists learn how to do something to help this patient. So
Mm-hmm.
I shows up on my doorstep, and I put the appliances in and I pushed the lower anterior teeth forward to reverse the retraction, which was done. The guy walks into my office and says, "My wife says I don't snore." And I said, "Joe, what do you mean? I barely moved your teeth. That's nutty. I can't believe that." And here I am calling his wife a liar, right?
Right.
She knows he's snoring or not. She's there, I'm not. But
Right.
I can't believe that the small amount of movement that I've already done made that difference. Uh, it's and that's how I got where I am, by listening to those patients. And who knows themselves better than the patient? You
Well,
know,
we assume we do. We know that
yeah, exactly.
authoritarian medical religious approach, like I know what you need. And
Exactly.
uh,
I know.
you remind me of me because the Serdentity, I took a little bit of this, a little bit of that, a little bit of knowledge from my own path of improvement, and
Right.
things I learned in therapy, things I learned about post traumatic stress disorder, things I picked up along the way, and from observing patients. And newsflash, it works. So you and I have had a very similar journey. Wow.
The salient thing here is, and it's the hardest thing, is to open your mind to the fact that what you learned in school may not have been the gospel.
Uh,
And particularly for me, I mean, I was the dutiful student. I overstudied for everything, and uh, I graduated at the top of my class, 92 students. Not because I was the smartest, but there was not one person who would work harder than Bill Hang. I could put more effort in than anyone. And so with that, I thought, well, gee, maybe I'm okay. I graduated at the top of my class. Maybe I know something. And
mm-hmm.
in reality, that's a very negative thing, because then you think you really do know something, and you trusted all the people who were in dental school who taught you these things. But when you really look at it, there's very little science in dentistry. Matter of fact, I have a quotation out of a journal article. It says, an academic guy from actually your state, I won't tell you where from in your state, from New York State, says that approximately 8% of what we do in dentistry is evidence-based. 8%. And yet,
8%.
oh, don't you love it when you go on someone's website and they say our practice is all evidence-based, and I just throw my head back and say, you're kidding. You live on another planet.
Right.
No one in dentistry, not one person in dentistry has an evidence-based practice. It does not exist. Uh,
Wow. And
I mean,
patients don't even care anyway. They don't care about empirical evidence. They care
no.
about anecdotal evidence. They care about what happened to their husband, their wife, whatever. And we're all like, "Oh, it's got to be evidence-based." And newsflash, studies are can be wrong and like intentionally misleading.
Now, I like to use this little interchange when I do a lecture. I always say to people, so how many of you take a medical, this is lecturing to dentists, how many of you take a medical history? And and they say, well, all of us do. Well, I do, I do. I said, yeah, you want to take a medical history because God forbid if you have a problem, you know, you need to know what's going on for this person. And I do this after someone would say to me, well, we can't trust what people say. They don't really, yeah, they can lie, they can exaggerate, they don't really know always what's going on for them. So when they say something's improved, can we really trust them or not? And so I always say, well, what is a medical history? After they say that they all take it. A medical history is nothing more than their version of what's happened in their life in terms of medicine. So I say, okay, fine. I had my tonsils taken out when I was about 12.
Mm-hmm.
Uh, Now, how many of you are you going to listen to me and believe me that I did or not? Will you then go research that and find that at Jarman Hospital in Tuscola, Illinois, in the late 1950s, probably 1958, that we found a medical record that Bill Hang had his tonsils taken out? Will you do that, or will you trust me that I fill out the medical history? You have to have that. Will you check that? And the point is, I've made my point. We listen. The medical history is nothing more than a bunch of stuff that someone puts down on a piece of paper indicating what's happened to them in their life. And yet we expect to have all this evidence-based stuff. Have you read Peter Attia's book? The most, he's a MD who's what is it called? Outlive the book. Uh,
Outlive. I'll have to remember that.
Read it. I read it earlier this year. He's a physician who, by I think it was his mid-30s, he finally realizes, despite him thinks he's in good health, he's not in good health, and so
Mm-hmm.
he decides he needs to start taking care of himself. And he goes into the whole subject of evidence-based versus evidence-informed, which is
Mm-hmm.
this evidence-informed. If we're going to look for all the RCT, random controlled trials, and the pyramid of evidence in dentistry before we're going to do anything, we're going down in flames because it's never going to happen. We can't. There's no way that these studies could ever be done with a control group that could end up with a negative outcome. It's not going to happen. So you have to go with what is evidence informed.
Mm-hmm.
It's very important for the profession to understand the difference, and you got to do the best that you can. The interesting thing is that in reality, what in the last 20 years of my practice, where I was trying to treat people in the primary dentition, and I did this very quietly. I didn't want to get on the radar screen too much because other people were not doing it. In reality, and I've later learned that orthodontists in the early 1900s were treating in the primary dentition, and
Mm-hmm.
doing so for health reasons. And they used terms like mental retardation. And,
Mm.
oh my gosh, no one would even say that today because that's politically incorrect to say that someone
Right,
might
right.
be retarded, right? We would never use that horrible term. But back in the days before we got so politically correct, we said things like that. And if you go back, there are several articles that I have out of the early 1900s talking about treating for those very reasons and treating in the primary dentition. Uh, it's so countercultural. And yet, even doing that today, our faces are so far back that
Mm-hmm.
even if we can get them forward, we may still have a problem. I mean, we're dealing with with a airway pandemic here. We haven't even clearly defined yet. And
Yes.
yes, the ADA in 2017, September 2017, says, okay, they have this nice statement, dentists should be screening for airway. Well, okay, that's September of 7 years ago, come
Right.
this September. And what has happened in dentistry? Is it widespread that people are being screened?
No.
I don't think so. Not at all.
But they're sure getting bleaching though. They're getting lots of bleaching.
Hey, you got to look good. Can't be too white.
So just so how come in the dental medical history, there's questions at the bottom? Oh, do you have to go? We've been talking a long time.
No, 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 I'm fine. No,
Okay.
I have to go.
I so you fill out your medical history, and then at the bottom, do you like your smile? It's like, hello, when I go to the doctor, they don't ask me if I like the appearance of my body parts. Okay. And my OBGYN could make some pretty good money getting a kickback from plastic surgeons to improve the appearance of certain body parts. But
Yep.
they don't, they just make sure they're functional and healthy. Why are we asking about appearance on a medical history?
Yeah,
Sorry, I got a little excited there.
we could have an interesting conversation for sure.
Oh my gosh. So yeah, we've been on here for almost an hour. I'm gonna probably have to publish this in two parts. Um,
Well, you have to do what you have to do. We've had a nice conversation. It's I think the big takeaway for me is that I think everyone who's a professional needs to ask questions. Um, in dental, I use this all the time. In dental school, I know that I was that person. I never, ever, ever would ask a provocative question to an instructor. I would never think of that. I would ask, how do you do that? Yes, how?
mhm.
Because after all, we are a mechanical profession.
Yes.
I chose dentistry because I knew that I had great eye-hand coordination. I carved wooden neckerchief slides as a Boy Scout, and I liked to work with my hands. So I decided dentistry was for me rather than medicine. So I knew the word how. How do you do that? Because I knew I would have to go out and do a profession where I would be doing things.
Mm-hmm.
In reality, we would be a lot farther down the path in knowledge in dentistry if every dentist asked the why question.
Yes.
If you're in
Why?
dental school, ask the instructor why. And that's kind of like the 2 or 3 year old kid asking mom why, asking dad why. Pretty soon the parent says, because I said so, right? Now,
Right.
tell me one parent who hasn't at some point gotten to that point and just look at that little kid and said, because I said so. Please just leave me alone here. We've
Oh
all,
my gosh, yes.
uh, but if we'd have all asked the instructors that why, whoa, they wouldn't have liked it because
Mm-hmm.
they were not informed either. And they
Mm-hmm.
were a student just like we were, taking in what we were told because we were not taught to ask those penetrating, sometimes uncomfortable questions
Mm-hmm.
that needed to be asked.
Yeah. Well, I can't thank you enough for speaking with me today, and you know, for yeah, for giving me the space to be able to speak my mind. And
Well, it's for me, it's a nice conversation to find someone else. You've had a slightly different path, but basically a path through the woods, very similar woods that we've both gone through. We've met different people along the way, but we've come to similar conclusions by listening to those patients, and then you realize uh, you'd like to go back in your career back to the first 20 years and say, oh my God, if I
mm-hmm.
knew when I started out what I know today, I could have really been a help to people.
Mm-hmm.
And I guess that's why they call it dental practice. But
Right, right, dental
when do you finally get good? Well, maybe by the time you retire, if you're lucky.
right, right. That's right. Right.
And I want to emphasize, believe me, I don't have all the answers, and none of us do.
No.
I'm a very humble person, and
Yes, you are.
I, I, I've been able to help a lot of people, but even toward the end of my practice, even with the best were able to do for certain people, some people's faces are back so far that even with the most sophisticated surgery, bringing the face forward and opening the airway up and giving them the biggest airway, they still can't be really that healthy, and we maybe not improve their maybe improve their health span a little bit, but not so much because there's so many other factors. There's
Hmm.
muscle tonicity where myofunctional therapy really comes in,
Hmm.
muscle tonicity, and there's a lot of other issues, vitamin D, and a lot of other
Yes.
many issues that we haven't even talked about. And sleep hygiene. I mean, oh my God, think about that.
Right.
And don't dare take away someone's cell phone that they use right up to the time that they turn out the lights and they put their cell phone down and then they go to bed and then they expect to go to sleep right away.
Right. Right.
I mean, we're really burying ourselves.
Yes. But you give me a lot of hope. And
Uh,
hope is the best. And that's what when I do my talks, when I do these podcasts, I want to let my fellow professionals know there is hope. There, things with an open mind, and we can be more proactive. We can be better.
I think what I see happening is that the pendulum has to swing so far to one side that it can't go any farther, and
Hmm.
we have to come back and get some sanity. And I think people have to realize that we could spend 100% of the gross national product on healthcare, and no one's going to get a bit better because what we have is a medical system that's broken. It's nothing more than sick care, and the only way you're going to get
Hmm.
healthy is if you take your own the responsibility for your own health in your hands, which was one of the reasons that I think the book by Peter Attia, Outlive, was a really excellent book. And I recommend it to a lot of people because it's, hey, you better take care of yourself. If you don't, who's going to?
Right. Well, again, I thank you.
Nice to
And
talk to you.
you too. I hope we see each other in person again sometime so we can
Okay.
sit down
All
and
right.
have a real nice face to face.
You bet. Thanks
All
so
right.
much for the opportunity. You have a good day.
You too. Bye bye.
Bye.